Namaskar. A very good evening to all the participants who have logged in for today's webinar. I, Dr. Mridula Trehan, extend warm greetings from NIMS Dental College and Hospital, NIMS University, Rajasthan, Jaipur. On behalf of Honorable President, Dental Council of India, Professor Dr. Dibyendu Mazumdar Sir, I welcome you all to the 17th webinar series of DCI. This brainchild of our Honorable President, Dr. Dibyendu Mazumdar, the DCI webinars have truly turned out to be a one-of-a-kind success. And for that, it is a pleasure to offer my heartiest congratulations to Honorable President Sir, Honorable Secretary Dr. Sabyasachi Saha, Executive Committee members, DCI members, and the technical team of DCI. This initiative has been a boon in these trying times and has succeeded in bringing our dental fraternity together. With utmost gratitude for the same, I once again welcome you all to today's webinar, the topic of which is orthodontic diagnosis and analysis of diagnostic records. And now, without further ado, I would like to begin by making a few announcements. At the time of registration, complete and proper details must be furnished since the same will be captured for generating certificate and CDE points. No request for any change or modification in their details shall be considered. So, all of you are requested to be very careful in filling your details. An e-certificate of attendance will be conferred to all attendees, including undergraduate students, international attendees, and non-dentists on their registered email. CDE points will be awarded to the dentists registered with state dental councils or tribunals of India. Certificates will be sent to the attendees by email within 3 days of conclusion of each webinar, only to those who have attended the entire session of webinar uninterrupted. You are also requested to kindly check your junk email folder just in case the certificate email got delivered there instead of your inbox. In case of any query or issue, please drop an email at webinardci@gmail.com. Participants can also view the archived webinars and download their certificates from the DCI website, dciindia.gov.in. A feedback link will be sent to you with the certificate email. All participants are requested to kindly spare some time and fill the feedback forms, as this will go a long way in helping us to further improve the quality of the webinars. The Dental Council of India appreciates and congratulates all undergraduate and postgraduate students, faculty members of all the dental colleges, and practitioners for attending DCI webinars in high numbers and making them a grand success. The colleges with the maximum attendance in the webinar held on 1st November 2020 were Saraswati Dental College, Lucknow, St. Joseph Dental College, Andhra Pradesh, People's College of Dental Sciences and Research Center, Bhopal, Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, and BJS Dental College Hospital and Research Institute, Ludhiana. Now, moving on to our speaker for the day, Dr. Ashok Sorana. He is a very well-known name in the dental fraternity, especially in the field of orthodontics. Dr. Ashok Sorana completed his postgraduate training in orthodontics from Government Dental College, Ahmedabad in the year 1992. He has maintained an immensely successful orthodontic practice in Kolkata for over a quarter of a century. Dr. Surana received the award for Best Clinical Paper at the 46th Indian Orthodontic Conference in the year 2011 at Khajuraho. He served as the organizing secretary of the highly successful 49th Indian Orthodontic Conference 2014 in Kolkata. Dr. Ashok Sorana served as the chairman of the Indian Board of Orthodontics for the year 2018. He was invited as the keynote speaker in the 12th World Mini Implant Anchorage Congress 2018. Dr. Surana has a special interest and a vast body of work in the use of skeletal anchorage for managing the vertical dimension. And let me tell you, management of vertical dimension in orthodontics is no easy feat. Today, he'll be speaking on the topic orthodontic diagnosis and analysis of diagnostic records, a topic of immense importance indeed, as we are all aware that successful orthodontic treatment begins with the correct diagnosis. With this, I invite Dr. Ashok Sorana to share with us his invaluable insight. Over to you, sir.
Thank you, Mridula ma'am, for being so generous. And it's a pleasure speaking to you all this afternoon. I thank, or in fact, I'm grateful to Professor Majumdar, a teacher of mine during my UG days, and the team DCI, especially Mridula ma'am and Dr. Mitali Vora and Dr. Mukesh Kumar, Dr. Sabyasachi and Dr. Virendra Goyal for providing this opportunity, working overtime to make this a success. Orthodontic diagnosis and analysis of orthodontic records is the subject of discussion today. During the last 100 years, we have progressed a long way from a simplistic treatment modality of aligning teeth to a science of therapeutic intervention in complexities of cranial, dental, and facial structures. Our vast social primate brains are evolved to pursue one central goal, and that's to look good in the eyes of the others. A balanced face is an outcome of intricate proportion and balance between hard tissues and the soft tissue drape, in function and in rest. Now, the main motivating factor which brings patients to our clinic is enhancement of appearance. And therefore, aesthetics is the principal goal in orthodontics. And rest, the other orthodontic objectives, are basically orthodontist's responsibility. So, there has been a shift from Engel's paradigm of achieving ideal occlusion to a more aesthetically focused soft tissue paradigm, which bases treatment on patients' overall benefit. The idea is to achieve an ideal aesthetic outcome and best function relationship. Every treatment decision with me begins with aesthetics. I, being a private practitioner, it is all the more important for me. That's the flow chart which shows you the way you approach the patient. Identifying malocclusion, diagnosing the variations in the malocclusions, and then doing a treatment planning, and then following it up long term. Arnett once commented, to improve our potential beyond, we must define our potential, we must define our mission beyond the exclusivity of occlusion correction. We must look beyond sagittal. There are other two dimensions also, vertical and transverse. And we must include, as a motive orthodontic treatment, the facial aesthetics and airway expansion. If we can do so, we are practicing the fullest scope of orthodontics. I explained to you the situation with a case report. Now we start examining the face. Let us examine the face, because facial harmony is our primary goal when we treat situations like this. Now, if you see the front face, it is a long face. The lower facial height is more than the upper facial height. And when we compare the anterior facial height to posterior facial height, the anterior facial height is more. And then there is incompetence of lips. The lips shows a huge incompetence. That means the interlabial gap is more than about 15 millimeters, with a full length incisal exposure at rest. And when she smiles, she shows gums. And when we see the profile, the anterior facial height is more than the posterior facial height, and the lower facial height, the lower third, is longer, with the neck area suffering because of the posterior rotation of the mandible, the growth rotation. The neck and chin are close by. That's the intraoral picture. She's in mixed dentition. When we examine the lateral cephalogram and the OPG, we see that she is in transition dentition, and whatever we concluded by examining her clinically is proved to be right. The dentures are protrusive. She is basically a bilateral protrusion with a vertical axis. This case was treated long time back when I was not into microimplants. So at that juncture, the best possible way to control the vertical were either a Pearson's chin cap or a high pull headgear. So in this case, we restrain the vertical so that she doesn't rotate clockwise, the mandible doesn't rotate clockwise. We get a proportionate face, and then to take the dentition back. Now that's the intraorals, and that's the post-treatment. So for reducing the protrusion, extractions were done. Naturally, when you want to retract, you have to extract. And that is where we finished a normal overjet and overbite with class 1 molar and canine, and the arches aligned. And that's the comparison. We have achieved a proportionate face. This is because we thought beyond sagittal, we thought beyond the exclusivity of occlusal correction and restrained the vertical. The diagnosis is a three-dimensional process, and we must not ignore the other two dimensions. The other two dimensions, one of them is vertical. Despite restraints, and because of the good cooperation of the patient who continued wearing a high pull chin cap to restrain her vertical. So that made the difference. The face became proportionate, this is one. And since we intruded and retracted the upper anteriors and we retracted the lower anteriors, we got the competence of the lips. That's the profiles compared. The improved neck chin area, you can see, because we could reverse onto a anti-clockwise rotation, and the dentures were taken back. Ideally, the job of an orthodontist is to optimally position the dentures in the face. And that's the smile. The gumminess is gone. The smile is fuller, and all other orthodontic aesthetic objectives which we want to see, like the smile arc, full buccal corridor fullness, is also there. But the story doesn't end here. Once treated, you must follow up the case for long and see what happens in the long term, because your long-term success depends upon the long-term stability and restoration and maintenance of the dentition. In fact, we should claim that post-orthodontics, the patient would be dental disease-free. Now that's the OPGs which has been compared, and you can see good uprighting, enough space for third molars to come, second molars also erupt. And that's when we compare the pre and post cephalograms. The dentures have moved back, the anteriors, upper and lower. The upper anteriors has been intruded, and a good vertical control with the development of the ramus, good growth at the ramus condyle complex. And anti-clockwise rotation of the mandible. In fact, the parameters which we take, like the SNA FMA angle, was also reduced in this case. That's the superimposition, good ramal growth, and restraining the anterior facial height, and then putting the dentures in the proper place. That is taking the upper denture up and back and the lowers back. That's after 5 years. So all possible corrections are being maintained. The profile is straight, the face is proportionate and attractive, the smile is fuller with all orthodontic aesthetic objectives fulfilled, and the front face is harmonious. That's the dentition showing good stability post 5 years. And that's a proud mother who sent me after a couple of years. So almost all the objectives, orthodontic objectives which we had in mind, and the patient's expectation. In fact, we have not just fulfilled patient's expectation, we have surpassed it. And that is only possible. This is more of a confirmation of the good diagnosis which we did by involving two dimensions, that is restraining the vertical and treating the sagittal. So we must move beyond the exclusivity of occlusal correction. We must think beyond sagittal. And aesthetics should be primary. Now, profit differentiated between diagnosis and treatment planning as a difference between truth and wisdom. So when you are diagnosing, your goal is the truth. That's factual appraisal of the situation. And there is no scope for bias, there's no scope for opinion or judgment. It's just the factual appraisal. We must go deep and find out what the patient looks like and what he or she has to offer us. And in the treatment planning, the goal is wisdom. Treatment planning is basically wisdom. A wise and a prudent clinician devises a plan, develops a plan, a treatment plan which maximizes benefit to the patient, which when the clinician offers the highest possible care which is required for the patient. So that's the difference. So diagnosis is basically recognizing and formulating the problem, carrying out necessary examinations, interpretation of results is what when you take up the diagnostic aids and your clinical exam, sum total of everything would put diagnosis into it. The whole issue is you must do a factual appraisal of the situation without being motivated elsewhere or without having a bias or without having a judgment. All these things would come when you formulate a treatment plan. So it begins with clinical examination, which is, I believe, most important since we have moved from the Engels paradigm to soft tissue paradigm. The best way to examine soft tissues is clinical rather than all other aids put together. And then study models and radiographic examination. To evaluate and document oral health, function and smile characteristics. And after clinical examination, you decide on the diagnostic records which are required. Clinical examination could be overall facial examination, whether the face is long, short, whether the infranasal height is more, less. Then the functional examination, that's examining the TMJ, whether the joints are stable or unstable. Soft tissue examination is a very important parameter if you are catering to aesthetic orthodontics, and hard tissue examination. So we begin with case history, study models, later on photographs, radiographs and wax bites. And supplemental aids could be 3D cephalograms, teleradiography, videography, 3D laser scan or occlusograms, which is not required in all situations. In particular situations, depending upon your clinical examination, you can use supplemental aids. Epker and Fish stated that perhaps the single most important feature in evaluating aesthetics is the relationship of lips to one another and to the teeth. Incisor-lip relationship are the key components of an immediate aesthetic outcome and thus patient satisfaction. Absence of lip seal or the increased incisal exposure are the features which are most responsible for unpleasantness in the face. It's unpleasant face or unpleasant experience of the patient. These are the two features which are most responsible. Now let's do an examination, the frontal face, the profile, then the intraoral examination, and temporomandibular joint examination. This is the way one should proceed. And then the facial fit. It's basically to determine the asymmetry. Asymmetry is a phenomenon which is basically seen in the lower third of the face. If you analyze all the asymmetric situations, about 74% of the situations, the lower face is affected. It is basically the presentation of the mandible which determines the asymmetry of the face. The mid face is less affected and the upper face is not affected at all. Very less. Particular emphasis should be given on the lower third of the face because that's the area which we manipulate to the greatest extent. The midline, reliability of the frenum, horizontal reference line to see the occlusal cants and deviation. Cants in the sense when you smile, one side shows more, the other side shows less. There is transverse discrepancy between the heights of the alveolar processes. I explain this by another clinical situation. You can see especially the lips are protrusive, and when you see the front face, the philtrum height is less than the commissure height, leading to the full length incisal exposure of the central incisor. This is the term which I use is a gullwing lip because it resembles a seagull in flight. The lip morphology resembles a seagull in flight, or it could be technically called a reverse resting lip line, where the philtrum height is smaller than the commissural height. So it's a reverse resting lip line resembling a frown. And when the patient smiles, it could be a hypermobile lip resulting in short and hypermobile lip, which accounts for the gumminess of the smile. So basically, Sarwar stated that when you have a huge interlabial gap, if the lip incompetence is huge, then in most cases you have a strong soft tissue component, which we must look for. There is a very strong soft tissue component into it, which is the philtrum height in this case is lacking. And we must find out surgical or orthodontic answers to it. I found out an orthodontic answer to this, and I'll show you the results also. So that's a bidental protrusion with molar and canine in class 1 and a deep bite. We have a scope to intrude the upper anteriors. That's the OPG. That's the cephalogram in which the upper anteriors are extruded. The huge incompetence of the lips is because of the anterior maxillary excess where the incisors have come down, and a short or a gullwing upper lip. That's the post-occlusion. Molar and canine is class 1, normal overjet and overbite. We have done in premolar extractions in this case so as to retract the dentures back. That's occlusion, and that's the post photographs. Now the lips are competent. That's unstrained closure of the lips. There is no incompetence. The lips are absolutely competent, and there is some amount of upper lip lengthening, and the gumminess of the smile is gone. That's post-OPG, and that is the cephalogram where the incisors have been taken up or back so as to elicit the best possible response of the upper lip. Now, facial soft tissue dimensions, we examine the lips in particular, because the most important aesthetic feature is the tooth to lip relationship and lip to lip relationship. The soft tissue dimensions greatly affect important aesthetic variables of patients undergoing orthodontic treatment, and we must examine them thoroughly. Evaluation of patient soft tissue presentation is a critical step in planning. Of course, we lack a credible soft tissue measurement system, a facial measurement system. Now, this is what Arnett stated, that we must analyze that why do we land up with situations which are less than ideal in terms of aesthetics. The quality of facial outcomes produced with now, and he investigated, and he was of the opinion that reduced the occlusal correction, you might get a class 1 molar and class 1 canine, but yet it might not be an ideal facial aesthetic outcome, or it is less than ideal aesthetic outcome because of our diagnosis, because we lacked in terms of diagnosis. Diagnosis in the sense that we had a model-based diagnosis. Han reported some time back that in most orthodontic situations, the only diagnostic aid which was used was a study model. In 50% of the situation in his sample, the only diagnostic aid used for diagnosing was models only. So such was the importance of models, and facial harmony not being the goal in these situations. The cranial-based cephalometrics, our cephalometrics is based on the cranial base, and there's lack of facial measurement system and lack of control of the occlusal plane contribute to poor facial outcome. Occlusal plane control means the vertical element. We are essentially talking in terms of sagittal and not controlling the vertical. So we need to control the vertical. Now, upper lip is a dynamic structure which varies to great degrees in smiling, speaking, and other functions. So we must be careful in not just determining the static relationship, but its relationship with the dentition on animation also, that smile. So you must take care of the upper incisor crown length, must analyze upper incisor exposure at rest and on animation, that's on smile, exposure of the upper incisor and gingiva on smiling, and in closed lip position. Now, the upper incisal exposure of say about 2 millimeters in males and about 3 to 5 millimeters in females is considered to be normal. But there is a qualification here. In a balanced lip and skeletal lens, from this position, the lip should ideally close to from a relaxed, separated position without lip mentalis and alar base strain. There should not be any strain in the alar base. There should not be any strain in the lips or in mentalis from this open mouth, normal incisal exposure to a closed mouth position. As I stated before, that absence of lip seal and increased incisal exposure are most annoying and most unpleasant experience for the patient. We must take care that those both are achieved post-orthodontics in situations which need. Another thing is to examine the soft tissues clinically, because they allow us into more specific breakdown of soft tissues into separate components like vermilion, philtrum, and commissural length, which is not possible on a cephalogram. Now, especially vermilion, which is affected, reduced, or improved with orthodontics. Types are competent, incompetent, potentially competent lips, and everted lips. Evaluation of the lip posture, protrusion, the lower lip hang. I was talking of this hypermobile gulping. Now, hypermobile means that when your lip shortens by more than 80% of its original length, then you should consider the lip to be hypermobile. Now, there's a difference in a gulping lip. There's a difference of 10 millimeters between the philtrum height and the commissural height, and no amount of growth. Most optimistic assessment would say that the philtrum height is going to improve till 18 years by 2 to 3 millimeters. So once a gulping, as Nanda and Ghosh stated, that once a gulping lip is there, it's going to remain there. We must find out remedial measures for it. So that's gulping lips feature. Full length incisal exposure of the centrals, less laterals, canines not seen, and a hypomobile means a gumminess of smile, almost a centimeter. She also has a vertical axis. So the huge lip incompetence is because of two factors. One is vertical axis and other is the soft tissue. In huge soft tissue, in huge incompetences where the interlabial gap is more than 10-15 millimeters, which has a strong soft tissue component, that means the soft tissue is aberrant. That is what Dickens and Sarver stated. Now, this is a comparison between a normal and a gulving lip. The gulving lip, the line which connects between the commissure and the labialis superioris is at an obtuse angle. This is what was stated before, that the pre-existing soft tissue morphology is likely to be the greatest determinant of behavior. So if you have an aberrant soft tissue, you're going to remain with aberrant soft tissue, but that's a myth. Modern day orthodontics and surgery takes care of all these things. I show you another situation where there's a huge soft tissue aberrancy. There's gummy smile, the gulving character of the upper lip. There's a huge difference between the philtrum height and the commissural height, and she's a class 2 with a hyperdivergent growth pattern. So when you examine, you see a convexity in the profile, huge lip incompetence, about 15 millimeters interlabial gap, and gumminess of smile. So that's the intraoral. And that's post-treatment. Now when you do a vertical control, the mandible, the growth of the mandible is redirected in more of a horizontal direction. So rather than being on a steeper occlusal plane and going down, it draws forward. So cogonium comes forward to a greater extent because of the vertical control of the maxilla. And when you intrude and retract, when you do a torque control retraction and intrusion of the upper anteriors, the upper lip also follows to a much greater extent. So that's, the lips have become competent, the closure is unstrained, and the gumminess of smile is gone. That's the occlusion. That's post-treatment cephalogram and PG. When we analyze the records, pre and post, that's the test that have we gone wrong or we moved in the right direction. The SNGOGN reduced by about 4 degrees. That means there's a perceptible good vertical control in this situation. And there's been a good intrusion of the upper molar as well as the upper anteriors, which redirected the growth of the mandible in a forward direction. So we got an additional P-point gains. So that's pre and post. Next, we move on to profile analysis to establish the anterior-posterior position of the jaws, the sagittal position of the jaws in relation to one another and to the cranial base. And we also evaluate the mandibular plane angle and evaluate this throat chin area. Previously, this area we as orthodontists were ignoring. In fact, I was ignoring because I thought that we will not be able to influence this in any great extent if the patient is a vertical grower. Horizontal growers, yes, you can get the mandible forward and influence the neck chin length. So that's the position of the jaws, convex, straight, and concave profile. So class 1, ortho, and then class 3. The best way to correct a jaw discrepancy is to let it grow. Let the patient grow out of it. I show you another situation which clarifies how does this profile analysis is important. Now, this situation, there's a hugely retrognathic mandible, and since the upper anteriors don't have stops, in fact, they have a glide in the form of a lower lip, they come down and forward. So they've got proclined and extruded, carrying gums with them. So the patient also has a gumminess of smile and a huge incompetence and the lower lip trap. Since the patient was growing and in transition dentition, the best idea is to get the lower jaw forward. So the diagnosis arrived was that one, the problem list is that there is a retrognathic mandible which should be brought forward by some functional appliances, and the upper anteriors should again be retracted and intruded so as to take care of the gumminess of the smile. So that at the end of the day, we land up with a good occlusion and good aesthetics. This is it. That's post-treatment. Now the lips are competent, the profile is straight, the gumminess of smile is gone, fulfilling almost all the orthodontic objectives and surpassing patients' expectations. That's post-treatment occlusion, molar and canine in class 1, normal overjet and overbite. That's occlusions. That's cephalogram and OPG. That's after 10 years. So we are holding on to all possible corrections. Sheridan once commented that you hold on to anteriors and let the posteriors adapt to diet, lifestyle, stress, and diet. So what we see in finished situation, in good occlusion, the dental diseases are taken care of, and there are minimal changes in terms of stress, which I show you in the next slide. So that's normal class 1 overjet and overbite, and molar and canine in class 1 relationship. That's after 15 years. She's become an adult, 31 years of age, showing signs of stress on the face, but dentition is as good as it used to be. So that's what is the celebration of orthodontics. That's occlusions. The patient's profile should be evaluated in a natural head position, clinically, in centric relationship, and the first tooth contact with relaxed lips. This is it. You examine the big face also. And then the mandibular area, especially the neck chin or neck throat junction. So this is the area which you can really influence if you do a good vertical control in posterior rotating growth pattern. And you improve on the airway also. Visualize treatment objective, that's bringing the mandible forward in horizontal growers and seeing if the profile improves, then the situation is fit for functional appliances. Now this is what, if you have a steep occlusal plane, like this boy, if you have a steeper occlusal plane, then if you try to get the mandible forward, the chin would go down and forward rather than coming up forward. So you must make a flat occlusal plane that's doing a good vertical control and letting the mandible come forward more horizontally. I show you two situations which require good vertical control so as to get mandible forward and to develop a straighter profile. Now by any standard, this is a very severe situation. When you examine the profile, it's almost a bird species. The diminutive condyle ramus complex and a smaller body with retrognathic mandible, a lower and the upper incisors getting a glide in the form of lower lip have got extruded and procline. And they've carried gums with them, so the smile is also gummy. There is some soft tissue aberrancy here because there is a reverse resting lip line resembling the front. So this is the intro. The treatment objectives. Now look at the cephalogram. We analyze. There's a reduced tramal and condylar complex, diminutive. One, two, there's a lower lip trap, and the mandible is retrognathic with a huge overjet. And that's the OPG. That's post-treatment. You need to take care of the steepness of the occlusal plane. One, you need to take care of the vertical so that the mandible grows in a horizontal direction and we get the chin more anteriorly as it is into a straighter profile. That's the front face smiling with no gumminess, and a balanced and a harmonious front face with no lip strain. That's the post-occlusion, molar and canine in class 1, and normal overjet and overbite. That's the occlusal pictures. My idea of showing you these results at the end of the day is to ascertain that you had gone right when you diagnose this case. And second, when you see a long-term follow-up and your case is standing the test of time, that's a confirmatory test of your correct diagnosis and planning which you did. So that's the OPG and cephalogram. We compare the numbers also. The huge A and B angle, 13.5 degrees, and a vertical grower with 40 degrees of SNGOGL. We had restrained the vertical descent of maxilla so as to flatten the occlusal plane and let the mandible grow more in a horizontal direction so that the class 2 is taken care of. Good amount of intrusion of the molars as well as of the anteriors. That's the superimposition, which shows increased ramal growth, movement of the maxilla in a horizontal direction, the pogonion, and the upper anteriors retracted and intruded. We also took care of the wedge effect by extracting the lower premolars, the upper first premolars and the lower second premolars in the extraction pattern. Another important entity is the nasolabial angle, which is very helpful in determining the final treatment for the customized patient. Now, with these things, these examination, we approach a very central and very pertinent question of extraction or to treat without extractions. I start with two situations just to give you an idea of what can be treated non-extraction. This is a girl who has a harmonious face, competent lips. The only thing when she smiles shows some lower incisors and the upper incisor exposure is less because she has a class 3 base. Now when we see inside the mouth, there's a posterior crust bite and the upper arch crowding and an anterior edge-to-edge bite with cross bites at the lateral incisor with the two canines highly avially placed. Now this transverse discrepancy between the upper and the lower arch really legitimizes the expansion of the upper arch. So you can expand, create space, and treat the case non-extraction. That's the cephalogram in OPG. That's the post-occlusal pictures, upper and lower occlusion, the buccal occlusion, and the front. Canine and molar in class 1, normal overjet and overbite, aligned arches. And that's the facial appearance. Now, these situations can be treated with extraction because you had ways and means to create space other than extraction. And in this case, it was the expansion, a rapid expansion, which was legitimate in this situation because there was a transverse discrepancy between the upper and the lower dentition. And hence, this expansion created enough space for alignment. And the upper incisor exposure has also improved with smile. The profile is better and the front face is harmonious and the lips are competent. Not much of a changes as regards the numbers in cephalometry. The pre and post compared looks much better. That's another situation where the face is okay, harmonious, lips are competent, the inclination of the upper and the lower anteriors are normal, but he has a crowding and a midline shift. The molars on one side is full class 2 and on the other side is endonish. So these are the cases which can again be treated with non-extraction methods by creating space or by developing the arches. In this case, a distalization was done so as to create space for the canine and shift the midline, or rather to max the midline. That's pre-cephalogram and OPG. That's post pictures, and that's the occlusion. The molar and canines are in class 1. The midlines are matching, normal overjet and overbite, and the arches are aligned. That's occlusions. That's post-cephalogram and OPG. The roots are parallel. Molar distalization, bilateral, and taken care of. Now, when you shift from that situation where there was mere crowding to a situation where there's crowding and protrusion and thick soft tissues, these are the situations which needs premolar extractions. So this is it. That's post-treatment occlusion. That's OPG and cephalogram. That's post-treatment facial appearance. The lips protrusion has been taken care of. All orthodontic objectives met, and the smile is fuller. There's another situation where facial concentrations are not much, but huge crowding. A discrepancy of more than 10 millimeters, very legitimate in extracting the premolars and treating it. We treated with premolar extractions. That's post pictures. That's post occlusion. That's after 5 years, looking the same. In fact, better than what we finished off with. That's occlusion post 5 years. That's occlusal pictures. That's after comparison between pre and post. That's after 10 years. Holding on to all dental correction, the face is good, but other signs have started appearing. She's lost hairs and all those things. But anyway, we maintain our part. The dentition is disease free and is in good occlusion and holding on to correction. The other part which we should take care is, as I stated, that 1, aesthetics is important. 2, we must go beyond sagittal. We must take care of the vertical proportions. Try and find out whether the patient is horizontally growing or vertically growing. She's a horizontal grower in the picture, or all proportionate faces. The lower and upper facial height is mid-facial, and the lower facial height are the same. And now we must take care of the lip. Lip is a very dynamic structure, and we must be careful not just assessing the lip static in rest, but we must see it in animation also, whether it's a hypermobile lip, or whether it's a short lip, or whether it's a gull lip. Now the normal lip length is 19 to 22 millimeters, 1 to 4 millimeters in the interlabial gap and the lower lip. I show you a situation in which there is a vertical excess, and vertical excess to the extent there's a huge incompetence, one because of the lip and other because of the vertical maxillary excess, and a huge gummy smile of almost a centimeter. That's occlusal pictures. 1/6 is missing on the right, upper right, and other 3 premolars extracted. That's post-treatment. The face is proportionate, gumminess is gone, the lips have become competent. So you must do an adequate vertical control in these hyperdivergent growth pattern. That's post pictures. That's the cephalograms compared. That's superimposition. And when you compare, the FMA reduced, it doesn't worsen. The SNGOGN also reduced. That means there's been good, adequate vertical control. And the axial inclination of the upper and lower anteriors were taken good care. That's pre and post compared. The lips have become competent. There's unstrained closure. Lip seal achieved. That's the gumminess gone. The face has become more proportionate. And that's the profile. The lower face is proportionate now and good neck chin. Now when we evaluate the neck chin area, that's Thus, the neck chin length improves when the mandible moves forward. And the best way to correct a class 2 is either you take the upper anteriors back, which flattens the nasolabial angle, but which makes the nasolabial angle obtuse, but there's a limitation to it. You can't go beyond 121 degrees. The other and the most preferred mode is to improve on the neck chin. So this is another situation where we have improved on the neck chin by getting the mandible forward. I show you this another situation, which is it's a complex kind of a malocclusion in which there is a class 2, there's a hyperdivergent growth pattern, there's incompetence of lip, there is soft tissue aberrancy in the form of a bulging lip, and there's gumminess of smile. We treated with vertical control and torque control retraction of the upper anteriors and intrusion of the upper anteriors. So this is the pre, that's the OPG, that's the post intraoral pictures, and that is the facial appearance change, which has taken care of all orthodontic and aesthetic objectives. In fact, we surpassed patient's expectation, and there's no gumminess of smile, the lips are competent. We improved on the neck chin area by doing more forward directing growth of the mandible by restraining the growth of the maxilla. And this is the OPG, that's cephalogram, this pre and post compared, and that's a 5-year follow-up. When you see a 5-year follow-up, it confirms that you were on the right track. You must follow up your own cases on a long-term basis so as to find out where did you go wrong. And this is one case in which she's improved since we finished off some 5 years back, and maintaining all possible correction. And when you compare the profile at the end of the treatment has improved in another 5 years because of the horizontally directed growth of the mandible. That's the other side of class 3 situation, a hugely depressed mid-face and a reverse. The good part is this, that she has a reduced face height, and we can improve on the face height by posterior rotation of the mandible and correct this class 3. That's post-treatment. That's post. That's pre and post compared. That's pre and post compared. That's pre and post compared. That's after 10 years. Looks better. Now I'll rush to some smile analysis, which you know better than myself. Microaesthetics, mini aesthetics. That's the smile scaffold, and then the intricate relationship between the gums and the teeth. That's proportion and connected areas. I show you another situation in which there is huge gumminess, almost a centimeter, and the crown height is much less than what it should be. So she requires intrusion of the upper anteriors and then crown lengthening. So this is it. Undertop incisors, virtually no lower incisors show on occlusion. So what you need to do is to restore the axial inclination and improve the upper anteriors. So that's at the end of the orthodontic treatment. We have left some gumminess is there because the crown height is also less. And if you intrude to the fullest extent, then despite doing a good crown lengthening procedure, the incisal exposure would not improve. So we've kept some gum show, and then now look at the crown height, which is much less than normal. And that's pre and post compared after doing a crown lengthening procedure. And let's compare the smile also. This is pre and post smile. Now this works. We've left some gums show and then do a crown lengthening procedure. The smile becomes all the more attractive. Microaesthetics. Pre, post, pre-post, pre and post smiles. Now, why are diagnostic records important? You have to ascertain that what you have seen clinically that needs to be confirmed. And to document the pre-treatment conditions of the patient, to monitor the growth changes, and for medical legal purpose also. Now, health of the teeth and oral structures, orthodontic records, and then alignment. Why diagnostic records are required? Panoramic X-ray and in some situations when you want to localize an impacted teeth, you need to go do a parallax, or maybe you can do a CBCT. Cephalograms, superimposition, just to trace the changes which has taken place during the treatment because of growth and because of the treatment. Study model evaluation, so much so important that Engel once commented that put plaster on the table, let's see what plaster do you have and put it on the table. That's basically judging an orthodontist by seeing his models. Now, Han stated that this is the most common diagnostic record, and see, in his study, 50% of the patients' decision was based on just one record, that was study model. So that's the importance of study model. But we need to improve on including facial harmony as one of our treatment goals. So scan and then intraoral scanning now. Arch asymmetry results you need to see on the casts, and then modern methods of 3D imaging, limitations of 2D imaging, you know better than what I do, advantages of 3-dimensional imaging, magnetic resonance imaging and cone beam computed tomography. And then the photographs. Now, photographs are something which can be appreciated, but not much of a diagnostic value in the sense, because you can't do direct measurements on them. If you want to measure soft tissue, the best method is to measure them clinically. That's another situation where incisors have been dumped in, and that's pre-radiograph and that's post. The changes which we want to show to the patient are best appreciated on photographs, but otherwise their importance is, for diagnostic purposes, is less, because you need some reliable measurement system which is clinically, or that's the changes. We taught the incisors, intruded and taught the incisors, which resulted in such a big change. Now, the limitations of two-dimensional photography is limited angles, influenced by photographic angle and distance, and does not permit linear measurements between landmarks. That's the most important part. You need to do direct clinical measurements. Or you need to do stereo photogrammetry, which you can do direct measurements because there's no distortions in the images. So if I conclude on this, I'm running out of time also. The advice is to careful clinical examination at rest and animation is a key to diagnose the underlying deformity. Knowledge of normal and abnormal soft tissue and hard tissue parameters should be at the fingertips of the clinician. You must know the normal to detect the abnormal. This is how I finish. It's celebration of life and denial of death. That's what orthodontics is all about. Thank you for being so patient with me. Thank you, Mridula Madam.
That was a wonderful presentation indeed, sir. Thank you for sharing your vast spectrum of knowledge and experience with all of us. The cases were very well finished, and the quality of your photographs was also par excellence. I would like to thank all the participants for the overwhelming response that we have received. Due to constraint of time, we will not be able to take up all the questions, but I would like to request Dr. Ashok Sorana to kindly address some of the queries posted by our participants. So the first question is that if someone is an orthodontic patient, then how much time will it take to remove the wires? Means what is the duration of orthodontic treatment? Many have asked this question, sir.
It should take about 15, 18 months roughly, or maybe 24 months, 1.5 to 2 years is a good time for an average case to finish off.
Yes, sir, depending on their malocclusion.
Depending on the malocclusion. Complex and difficult cases take longer, but otherwise, comprehensive orthodontics, we finish off most of our cases maybe 18 to 24 months or 30 months at best.
Yes, sir. One viewer has asked, what is the scope of orthodontics?
Sky is the limit.
Yes, sir.
Sky is absolutely the limit. With newer innovation, orthodontics is growing and growing. The only problem which modern day orthodontists are facing is the numbers. But Professor Julian Simon stated that this concern with numbers is misplaced. What is important is the training of the orthodontist. The human intelligence should be unimpaired, and the numbers would take care of themselves.
Yes,
so the scope is immense.
Very true, sir. So one viewer wants to know, if the patient has a class 4 fractured central incisor, then what is better to do? To restore prior to orthodontic treatment or to restore after completion of orthodontic treatment?
You have to restore it. You have to ascertain whether he requires an endodontic intervention or not. If he requires an endodontic intervention, then endodontic needs to be done before you begin with orthodontics. Maybe you don't fill it up with the usual material, do some calcium hydroxide and then replace it. These things endodontists know best, but you need to restore.
Yes, sir. Yes,
if
sir.
the non-vital tooth, yes, it needs to be restored. And as it is, if it is broken and vital, then also it should be restored so that you get a proper morphology.
True, very true, sir. Sir, many viewers want to know that what is the sequence of doing treatment with abnormalities like maxillary constriction, proclination, open bite. What is the sequence of the treatment, sir?
The transverse part should be taken care first. Transverse discrepancy influences the sagittal discrepancy also. Most orthodontic students will be learning that feet and shoe effect. If you expand the maxilla, the mandible takes its normal position. So transversely, if you have a constricted maxilla, you should expand first. And there are other benefits also. Some people say that we are competing with this procedure with the ENT people in expanding the airway. We are competitors as far as the upper airway is concerned.
Yes, sir. Thank you, sir. Some viewers want to know the effect of orthodontic treatment on the roots of the teeth. Is it a positive effect or is it a negative effect?
There's nothing negative about it. We hardly see resorption. We hardly see if your forces are light forces is most important. There is some when you improve on the forces, then the resorption potential also goes up. So one has to be careful about the forces, ma'am. Especially in inclusion, you require very light forces. And for orthodontic treatment also, if you are moving bodily, the forces should be light. Nothing other than light forces.
Yes, sir. That is most important, sir. Now, many viewers want to ask the ideal age of orthodontic treatment and till what age can we go in for orthodontic treatment, sir?
There is no upper limit for orthodontic treatment. There is no upper limit provided
the periodontal health.
Periodontal health is good. Your periodontium is good. Your joints are stable. There's no upper limit you can do at any point of time. In fact, it restores both also. And as regards the lower limit, you need to find out a cooperative patient. If the patient cooperates, you can start early. But especially with class 2, there are trials which say that there's nothing are we gaining by starting too early. So transition dentition should be an ideal time. The consultation should be before, but transition dentition, say about 9 years, is a good time to start 9 years.
Sir, One viewer wants to know how to differentiate between true and pseudo deep bite, sir.
True deep bite is basically when the facial height is less. It's a horizontally growing pattern, and the jaw is a square, the face is a square face, and the mandibular plane is absolutely parallel to the floor, like mine. And pseudo deep bite is something in which the anteriors have got extruded. Anteriors have got extruded, and the treatment is again intrusion. And on those cases, it's a vertically growing pattern. It's a hyperdivergent growth pattern where the face is not square; it's a long face. Long face with deep bite is mostly pseudo deep bite, and short face and deep bite, it's a true deep bite, where the molars have not erupted to the fullest potential.
Thank you, sir. One viewer wants to know that she's saying that we often see midline shift during the orthodontic treatment. How can we avoid it?
In fact, you correct midline shift with orthodontic treatment. That's one of the objectives, that you must match the midlines with the facial midline as well as the interarch midline. This is one of the objectives. You must correct the midline.
Then one
lopsided and canted midline is anesthetic. One is lopsided, yes. You shift. That shift is again, there are acceptable limits to shift. Say if you shift by 3-4 millimeters and parallel to the facial midline, it's not noticeable to the layperson. But if you have a canted midline, then you need to correct it.
Sir, one participant wants to know how to differentiate between skeletal and dental malocclusion in class 3.
Cephalometrics, or you need to check on the pseudo component. Pseudo component is basically normal size mandible which has been positionally put forward. So pseudo, if you can rule out, then you can differentiate between what is a true and what is a dental. It could be a cross bite, but when you put the mandible in centric, there's either an edge-to-edge bite or a normal bite.
One participant wants to know the significance of profile view, means the lateral cephalogram, as part of diagnosis, sir.
It's the basis of orthodontic diagnosis for years together. Of course, our reliance on cephalometrics has reduced because we had, as Arnett pointed out, that we relied on a cranial-based cephalometrics. We should have facial measurement systems and other ways to diagnose now. But I personally feel that puts scientific basis to orthodontics. Otherwise, though, everything would be hunky-dory here and there. It's important.
So the next is
required. All orthodontists, in terms of records, at least take cephalometrics and does cephalometrics and analyze it and then do it.
Yes, sir. The next question is how to proceed in case of hypotonic lips and lip trap with orthodontic correction in mixed dentition period, sir.
Lip trap you can remove by, sometimes if you have a retromandible, you can get the mandible forward, check a video. If that goes off, then the lip trap is gone. And hypotonic, you need to improve on the tone. I showed you some cases with dulling and other things where there was short upper lip. They also respond well. They grow during treatment and they respond to orthodontic maneuvers also. But lip trap, either you need to get the mandible forward to cover up the overjet, and that helps, or you can put up a lip bumper also. It used to be a popular appliance. Even some time back.
Hello?
This is connecting. Yes, ma'am.
Yes, sir. So the next question is orthodontic treatment fully safe for our teeth? Means what are the effects on other normal teeth and tissues of this treatment, sir?
Orthodontic treatment has a history of more than a century now. It's definitely very safe. There are no issues about it. But the patient has to take care of his dentition. Hygiene is a big issue with kids, and that might lead to inflammation of the gums and decals. But there are ways and means to prevent it. And all orthodontists practice this to the fullest extent.
Yes, sir. Sir, many viewers want to know which braces give better results, labial or lingual, without taking aesthetics under consideration, sir.
Both would give good results. Both would give good results.
Yes, sir.
There are no limitations as such. The systems on both sides are well developed.
Yes, sir. So the next question is, which is the easiest malocclusion to treat?
Anything is very easy to treat provided you diagnose it properly and you have a plan to do it. But unless and until you're thorough with the diagnosis and planning, you shouldn't embark on it.
Sir, the next question is extraction of tooth or teeth necessary for every orthodontic treatment?
No.
Yes, sir. It will depend on the malocclusion.
If you have a severe malocclusion, the space requirement is more, as I showed you cases where there's protrusion, extractions are required. But otherwise, you can treat a lot of things non-extraction. This is especially for people who diagnose and have extractions as a part of orthodontic treatment.
Yes,
There
sir.
are people who treat everything non-extraction.
Now, the final question is how to treat a gummy smile, sir?
I've showed many gummy smiles. Implants have made, micro implants have made our life very easy. And as far as treatment of gummy smiles, the first choice is micro implants, which used to be surgery. So surgery is no longer the choice. We can treat most gummy smiles with micro implants. It's basically intrusion of the posteriors as well as of the anteriors.
Thank you so much, sir, for answering the questions so patiently. And with this, we come to the end of the question answer session.
I would like to thank Mridula ma'am for convening this whole session in such a in such a manner. One, and then the team DCI with Dr. Shah, Dr. Mukesh Kumar, and Dr. Virendra Goyal. And I must express my deepest sense of gratitude towards the President Dental Council of India, Dr. Dibyendu Majumdar, for providing this opportunity so that I can speak this afternoon. And I will be failing if I don't thank enough my junior colleagues who worked with me to put these results in place to treat patients, and they were instrumental in this presentation also. Dr. Anvesha, Dr. Grewal, Dr. Ashray, and others. I thank them. Thank you. And the viewers for being patient and taking time out and providing me an opportunity so that I can convey whatever little orthodontics I do. Thank you, ma'am.
Thank you, sir. Now, once again, DCI recognizes the top 5 dental colleges with highest attendance in the last webinar. These colleges were Saraswati Dental College, Lucknow, St. Joseph Dental College, Andhra Pradesh, People's College of Dental Sciences and Research Center, Bhopal, Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, and BJS Dental College Hospital and Research Institute, Ludhiana. Now, owing to the Festival of Lights, Diwali, there will be no webinar this weekend. The next webinar will be on 22nd November 2020, the topic of which is Diseases of Dental Pulp. Subtopic, Pathways of Pulpal Infections, Clinico-Pathological Correlation and Diagnosis. The speaker for the webinar will be Dr. R. Paul, former member of DCI and former principal, Guru Nanak Institute of Dental Sciences and Research, Kolkata. The webinar will be moderated by Dr. Suresh Valpande, ex-Dean, Government Dental College, Aurangabad. With this, we have reached the last leg of today's webinar. What started as a noble initiative by DCI has metamorphosed into a great learning experience for the dental fraternity. It has truly resulted in the benefaction of students, faculty, and practitioners alike. I am humbled to have been able to be a part of today's webinar and would like to extend my deepest gratitude to our dynamic President, Honorable Dr. Dibyendu Mazumdar Sir, Honorable Secretary, Dr. Sabyasachi Saha, Executive Committee members, and DCI members. I would also like to take this opportunity to appreciate the tireless efforts of Mr. Mukesh Kumar, Deputy Secretary DCI, Dr. Virender Goyal, Professor and Head Department of Pediatric and Preventive Dentistry, Guru Nanak Dev Dental College and Research Institute, Sunam, and the entire technical team of DCI in ensuring the seamless execution of today's event. That's all for today. I sincerely hope that this was an educational and informative experience for all of you. I once again thank all the attendees and wish you all a safe, happy and prosperous Diwali. Stay safe and healthy. Thank you.